Hi guys and welcome. I had said that I'm going to be coming live today at 2 o'clock and we are going to talk about something. It is going to be a short and sweet thing, but we are going to talk about something which is very, very important, especially for people who are practicing fertility or for people who are referring patients to fertility specialists, right? Now, we all know it's an open secret that everybody has some or the other friend who is doing good fertility work. There is absolutely no doubt about that, right? But one thing, if you ask your dear fertility specialist, which always is an enigma, is a question mark, is the implantation, right? We will make very good embryos. People who do work in azoospermia and low sperm counts and low AMH also end up making excellent embryos. All those things are like without a question, like there is absolutely no doubt in anyone's mind that one may or may not form embryos. Those things are really now out of question. So what is the question? When you have good embryos, what is your approximate estimated success rate of implantation? One thing which is very important for people to remember as far as implantation is concerned, remember, these are very salient points. So next time you can probably discuss this with your patient, and simultaneously I'm going to be very happy if people cross question me on this. You can cross question me and you can put a counter that Jay, you are wrong in this, right? And I'll be very, very happy if somebody does that. So one of the most important things people must remember is that implantation is actually a microscopic procedure which happens between the embryo and the endometrium. All right. So let's assume my right hand is the endometrium and my left hand is the embryo. Now this is a microscopic procedure which develops. You need not have the entire endometrium as brilliant as that particular location, right, for the implantation to occur. So that is one very important thing which people must remember. Second, you must remember is that despite an endometrium which looks morphologically good, when you are looking at a morphologically good endometrium, probably you are trying to look at something called as the triple line, right? And on top of it, you are also adding vascularity inside it. So this is something which helps us identify that yes, the endometrium is at least looking good. And when the endometrium looks good, we believe that it has a higher chance of implantation. But remember, one very important catch here. All IVF centers would do an embryo transfer on a very good endometrium. I'm yet to see or speak to an IVF consultant who prepares a poor endometrium and does an embryo transfer. So that means despite all guys putting embryos inside morphologically, visually normal, wonderful endometrium, the implantation is still approximately 35%, sometimes 40%. If you are changing the gametes very rampantly for clinics who are predominantly practicing donor embryos and donor sperms and donor eggs and all these things, the success rate is approximately 40% on the higher side, irrespective of what they achieve in a particular month. Let's assume somebody tells you that their success rate is 90%. That is wonderful. But it's 90%. Let's say if they did 10 patients and 9 patients became pregnant, so their success rate is 90%. But if you look at an overall average of, let's say, 18 months of a particular IVF clinic or a particular fertility establishment, you are going to identify that broadly speaking, the success rate, even if you are using third-party reproduction, is going to be in the range of around 45, sometimes 50%, right? For clinics who are predominantly using just self-gametes, that means husband sperms and wife's eggs, irrespective of the circumstances, your success rates of implantation are going to be much, much, much lower. And when I talk of lower success rates, it's going to be approximately in the range of around 25, sometimes 30, sometimes 18, sometimes 32. But in that range, so broadly we can look at it as around 25 to 30% and probably not more than that. All right. Another important thing as far as endometrial receptivity is concerned, one thing we know now is that for clinics who practice natural cycle transfers, the implantation is slightly on the higher side, just slightly. The reason for that being the window of implantation is believed to be wider when you are doing a natural cycle embryo transfer as against a hormonally prepared endometrial transfer, right? But again, there is no statistically significant difference. If you look at data from clinics like us, where we do natural cycle transfers in approximately 20% of the patients, and the rest of the patients are on artificial preparation of endometrium, I think the overall success rate just differs by maybe 2 or 3% and not more than that. It is also very important for people to understand that though we look at the endometrium thickness as such to be 7 millimeters or more than 7 millimeters, somebody would say more than 8 millimeters, the broad average across the country remains 7 to 9 millimeters. But that doesn't mean that when somebody has an endometrium which is 6 millimeters, it is a bad endometrium. It really doesn't mean that. For that particular lady, if 6 millimeters is a good endometrium, she's going to conceive, the embryo is going to grow, and she's going to have a successful pregnancy outcome. So that is one thing which people must keep in their head. You must also remember one very important thing when it comes to endometrial preparation. Look, the endometrium which grows, right? It has microscopic receptors to estrogen and progesterone, right? Now, even if the patient has a bath in progesterone and estrogen, the amount of estrogen which the endometrium is going to absorb is going to be limited. The amount of progesterone which the endometrium is going to absorb inside it is also going to be limited, because by increasing the dosages of progesterone, you may not increase the progesterone receptors which are present in the endometrial cavity. So that is one very important take-home point. Also, we believe that use of adjuvants, especially adjuvants like arginine sachets, which increase the nitrous oxide production, sildenafil, which is believed to increase the vascularity, at their very best, they have an extremely limited role. At their very best, they have an extremely limited role. All right. For a normal preparation of the endometrium, I believe the standard dosages of estradiol valerate are followed by most of the fertility specialists. But if you are having a thin endometrium on hormonal preparation, the first step should be to go ahead with a natural cycle preparation. Trust me, you are going to be surprised and amazed at the vascularity which develops in the endometrium when it is prepared naturally, or an endogenous stimulation with the estrogen which is secreted from the corpus luteum. And that, if it fails, only then you must consider options like putting a hysteroscopic PRP or an intrauterine autologous stem cell transplantation. Everything else which has been reported at best has extremely limited effects. All right. And finally, I want to clear this concept of ERA, which is endometrial receptivity. Now, remember, what is ERA? ERA allows you to probably give you a mapping of how many genes are upregulated and how many genes are downregulated and all these things. But there are 2 or 3 important things, right? Now, this thing is predominantly standardized for women who are outside India. That is one thing. Second, your preparation and your absorption is cycle dependent. So let's assume I do an ERA for a patient in the month of October. The report is not going to be valid beyond probably November or December, right? It's not going to serve purpose. If you believe that ERA gives you a window of implantation and it tells you that, the endometrium is post-receptive, so you need to do a transfer on the 4th day, or if it is pre-receptive, so you need to do a transfer on the 6th day or the 7th day, you must remember one thing. Even if you transfer as per the ERA report, it does not increase the success rates. It does not increase the success rates, because when you are taking the biopsy from ERA, you are taking a broad biopsy of the endometrial cavity. But the actual implantation is going to be a microscopic process. And I believe, and I very strongly believe in this after doing a lot of ERA. So we would be doing a lot of ERA tests in our hospital, and now we very firmly believe that at its very best, the benefit which ERA offers to the patient as far as implantation is concerned is extremely limited. All right. At its very best, it is extremely limited. And I would really want to have opinion of my friends, especially Chinmay, Dr. Chinmay Patki. He's a very good guy. He's done good amount of work on ERA, and I hope if he sees this video, he gives a comment on his input on ERA regarding this. Ultimately, one thing which really helps in implantation and which probably people tend to miss out on, all right, is extremely good lab work. Remember, this is a point which is somehow or unfortunately never included in most of the times, and we are busy talking about how to prepare and how not to prepare. But remember, a good freezing, a good thawing, and a good laboratory work is something which is going to definitely add that 2 or 3% to your implantation. So my appeal to all my friends who are practicing fertility, to all friends who are stimulating patients and taking them to a close by fertility clinic, and sending patients and doing their transfers and pickups at those places, is to ensure that you are supervising your lab work. That is something which is going to change the game. If an embryo selection is done by a good guy, like a good person who knows how to select the embryo, who has observed how the embryo goes on day 3 and how the day 3 embryo goes till day 5 and then how it looks on day 5, that is something which is really going to help you increase your implantation rates for these embryos. And finally, before we finish, just one small misconception which people have, and I'm sure a lot of people are going to agree to this, is that normally, if you were to transfer 3 embryos which are day 3, all right, it is going to be equivalent to transferring 1 embryo which is a blastocyst. I believe most of the good clinics across the world have shifted to blastocyst transfers, and it is high time that we ensure our laboratory conditions are good and we shift to blastocyst transfers for almost all patients as far as possible, because that is something which really helps us standardize the gradation of the blastocyst, thereby giving us a good perspective of the possible implantation. And lastly, just remember, if the endometrium is good, embryo is good, everything is good, right? IVF is still, fortunately or unfortunately, an age-dependent parameter. Implantation rates 100% go down when the maternal age crosses 34 or 35 in India. In fact, most of the fertility friends, especially our generation, is going to agree to us that these days in India, we get a lot of women who are at age 31, 32, 33, 35 and whatever, and have very low AMH, thereby resulting in very poor embryos and thereby resulting in very poor success rates. All right. So implantation, as age keeps on going up, the implantation keeps on going down. It is going to be virtually very difficult to cross implantation or success rates or clinical pregnancy rates of more than 30% when the age of the mother crosses 35. It is going to be very difficult to cross success rates of more than 15 to 20% when the maternal age crosses age 40, as long as you are using her own eggs and husband's own sperms. Probably when you use third party, the success rates might go up, but it is not going to double from there, because ultimately the age of the uterus is an old uterus. And I think these are some very fine, important, basic points regarding implantation of the embryo, which all the colleagues who are practicing fertility or are referring patients to their fertility friends should remember. This will help you in positive counseling of your patients. Remember, as I said, your success rates could be very good. IVF success rates at some centers, what they publicize, is going to be 50% and 80% and whatever. But that is going to be probably for that month or probably for that quarter. So don't get carried away. Don't feel dejected that why somebody is at 70% and why somebody you are at at 30% or whatever. If you look at the broad average and if you ask people very genuine data, they are going to come up with very similar statistics. Because remember, had that been the case, only guys who are offering 50, 80, 90% plus success rates would be surviving. People with lower success rates probably would not be in existence by now. Okay. This was a very direct, very open session as far as implantation is concerned. I really hope this helps you counsel your patients positively and in the correct manner, because this is what causes one of the most important reasons for failing IVF, due to which patients keep on running around here and there. And any further questions to this can be on WhatsApp or on the comments here, and I think I shall be very happy to answer them. So thank you so much everyone for joining in.